Good morning. Thank you for joining me. I'm Dr. Tom Raff. I'm the Associate Director for LGH Penn Medicine's Urgent Care, and we're going to be presenting to you what's new with the flu. We have three speakers here today. We're going to be reviewing what has happened with the flu, treatments for the flu, and then future directions. So I want to introduce our faculty. Dr. Paul Auwaerter is the Sherilyn and Ken Fisher Professor of Medicine at Johns Hopkins University, and he is the Clinical Director of the Division of Infectious Disease and the Director of the Sherilyn and Ken Fisher Center for Environmental Infectious Disease. He's the Executive Director of the Johns Hopkins Point of Care Information Technology Center, and he's also the Editor-in-Chief of the Johns Hopkins Antibiotic Guide, which is that little guide that everyone keeps in their jacket on rounds. Wonderful resource. He is also the past president of the Infectious Disease Society of America, which is the largest infectious disease society in the world. Our second speaker is Dr. John DeMornay. Dr. DeMornay took his medical degree at the University Medical Center of Haiti. He then did his residency here at the Lancaster General Family Medicine Residency in Lancaster, Pennsylvania. And he has been working in urgent care and emergency room medicine for the last 10 to 12 years. And I'm Dr. Tom Raff. I took my degree at the Medical College of Virginia, VCU, and I also did my residency here at Lancaster General, was in private practice in Lidditz, and then academics for approximately 19 years, and then have been back here with urgent care for the last 2 to 3 years. We're going to move on with a few standard things. Financial relationships, and the activity is supported by an educational grant from Genentech, which has had no influence whatsoever in the presentation or the editing of what is going to be presented. And Dr. DeMornay and I have had a lot of input into this, so just be aware of that. Our objectives today are to explain and apply the CDC guidelines for vaccination and initiation of antibiotic treatment, demonstrate effective communication techniques to address perceptions of symptoms, severity, vaccination measures, and therapeutic safety and efficacy of vaccines and antiviral treatments for influenza, and then assess profiles of antiviral therapies that are used to treat influenza. So we're going to start, the structure is going to be a discussion of influenza by the numbers, which I will do, and then a section on prevention, diagnosis, and management, which I will also do. And then I'm going to turn it over to Dr. DeMornay, who will address knowledge and attitudes towards influenza, or i.e. those difficult conversations trying to find out where a patient is and where they need to be or where we think they should be. And then Dr. Auwaerter will talk a little bit more about evolving management and new medications. And then we'll have a question and answers. At the end, we do have a microphone here, so we'll pass that out to anybody that has a question. So let's talk about the numbers. So last year was one of the longest seasons, but thankfully not the most severe season we've had in many years. There were 127 pediatric deaths, which was down from the record high of the year before, 185, which those of us in urgent care still have PTSD over. There was about 40 million individuals affected last year with symptomatic disease, accounting for about 20 million visits, and there was about 500,000 hospitalizations, and up to 80,000 deaths if you include pneumonia and other complications. So as they say, no one really dies of flu. You die of the pneumonia you get after you have the flu. This is what the year looked like. The numbers at the bottom are the weeks of the year. So number week one is January 1st. And this was what LGH's year looked like last year. As you can see, it was a long season, but not a particularly high peak compared to other years. And then this is length of stays. So most patients would be in and out of the hospital within 4 or 5 days, but of course you have people with multiple morbidities who just in for months and months on end. We saw a lot of influenza A, and most of this was occurring in the outpatient setting, but we did see about 17% of our positives were inpatients, and most of them landed in the med-surg units, although, as you can see, about 17% were in the critical care units. This is the percentage of visits for influenza-like illnesses, ILIs, and you basically see the 2.5%. That's the ER visits in blue versus the overall visits. And then the circulating strain, as I mentioned, 75% or so was Influenza A. Looking at what's going on now, the canary in the coal mine for us is Australia in the southern hemisphere, because influenza basically moves south for the summer and then comes north for the winter. And you can see that there's a high amount of activity in Africa and Australia and Indonesia. So we're expecting a fairly brisk year this year. And if you look at this graph, the orange in, do I have a pointer? The orange, the high peak there was the 2017 year, and then the orange was last year. So you can see we had a long season, but not as severe. And this is what is going on currently as of the middle of November. Red is high incidence of influenza-like illnesses, and then the green states are states that have not had a lot going on yet. And then this is our current data as of Friday of last week. So we're starting to see a total of 30 cases at the moment, most of it being Influenza A. And so now I'm going to shift gears a little bit and talk about prevention and diagnosis. So as we all know, the best way to prevent is to immunize. It prevents about 7 million illnesses, about 100,000 hospitalizations, and up to 8,000 deaths if you can get people immunized, and many of these being deaths in children under age 5. The coverage vaccinations rates for 2018 were somewhere around 60% for the 6-month to 17-year-olds, and then about 45% for the adults. Everybody basically needs to be immunized unless they have some very rare instances, unless they are allergic to the influenza vaccination, have had problems in the past. People at high risk are particularly young children, 6 months and older, adults over age 50, people with any kind of chronic significant disease, including diabetes, which seems to be extremely prevalent, but metabolic disease, obesity, immunocompromised, obviously. Pregnancy is a very high risk for influenza and complications, so all pregnant patients should be immunized if at all possible, and then residents of nursing homes and Native Americans. We have multiple options. We have a quadrivalent vaccine, a trivalent vaccine, and then multiple ways to give that, including a jet injector, the flu shot, and a nasal spray. Anybody working in a high-risk environment, basically everybody in this room, or living with high-risk individuals. So anybody in the family, they're likely to be closely in contact with any of those high-risk individuals, should be immunized. And of course, daycares, elementary schools, and high schools. Chemo prophylaxis, so if someone has not been immunized, but they come in contact with someone who is having influenza, then they need to be chemoprophylaxed. And that would be people who had the influenza shot and have within 2 weeks of the current exposure. Those people haven't yet developed immunity, so they do need to be considered for chemoprophylaxis. Those at high risk for influenza or complications, so someone who maybe refused the vaccination, a family member comes for Thanksgiving and it turns out the family member has influenza, and grandpa refused the vaccination, grandpa needs to be chemoprophylaxed if in the next 2 weeks. People with immunodeficiency, obviously, and the chemoprophylaxis at this point is primarily Tamiflu. It is moderately effective, dosed at 75 milligrams a day. Basic symptoms of the cold or the flu. As you know, sometimes it's hard to sort out. I really want this poster in every room in urgent care so that patients, as they're waiting for their, or thinking about their flu swab, can sit there and look at this and compare their own symptoms to what they're, I want to put strep on there too, their own symptoms compared to what they're experiencing. So a general classic case would be a 19-year-old who comes in, 2 days of cough, fever, exhaustion, myalgias, nausea, too weak to go to class. So they basically feel like they've been run over by a truck. I usually ask them that, and they usually say, oh, yeah, I feel like I've been run over. No severe distress, but a temperature, fevers, and a pulse that would indicate a temperature. They usually have a fairly benign appearing exam in terms of what, when you listen, you don't find localizing symptoms. So the question is, when do you suspect flu, and what are the risk assessment of complications, both of the patient and the environment that they're around? Because if the patient themselves is healthy, but they're a daycare worker, or they have a family member who has cancer and is on chemotherapy, then that family member may need to be chemo prophylaxed, even if the patient is healthy enough to ride out the flu themselves. So you want to decide to yourself, does this person need to be tested because I need to treat them, or do they maybe need to be tested because I need to treat that high-risk family member that they're in exposure to? And we often see this with folks who come in who have a pregnant spouse and they're worried about the spouse getting flu, or they have young children at home. Double sickening is that complication where they have the flu, they're sort of perking along, they get a little bit better, and then suddenly they get worse. They get that secondary illness, and that secondary illness may be that pneumonia that goes on to kill them. So you have to be aware of that. And then, as I mentioned, who are they in contact with? And these are all the medical conditions of the people they may be in contact with that you have to keep in mind. So it can be quite a little bit of a discussion about who are you around and who may you be associated with, and who could you make sick if you're not sick yourself. And our testing now, we have basically a lot of options. The rapid diagnostic tests, which are molecular tests, have a very high sensitivity and specificity. That's what we tend to use. They take about a half an hour in our facility, but they do give you a very trustworthy answer that you can act on if you need it. Now, clinically, you may not need it. The patient may not, particularly if you're in an epidemic portion of the year, which kind of we'll talk about in a second. So these tests are simple to perform, quick results, fairly low cost, and really a lot of very few false negatives and false positives. So they're preferred. Okay. Now we're going to switch into addressing the knowledge and attitudes towards influenza, which is often one of our greatest challenges. I'll ask Dave to come up and take over at this point.
Okay, thank you everybody to be here. I would like to address maybe the part of the visit that will not be straightforward. We know as physicians, we always want to have something clear-cut. The patient came, they have symptoms, we already are working on a plan in our heads, we know what we're going to offer, and then we hit a wall. Or the patient doesn't really believe, or I heard, or my neighbors, or if my friend had these symptoms and he get this or that. And when we hit these situations, that's when we as physicians need to take a step back, try to understand what's happening, and recalibrate, if I can say, the visit and see how we can help the patient. We are going to talk about the health belief model. And there are a few things the patient will come with. They come not only with their disease that we have to understand and address, but they come with their baggage, their religion, their upbringing, what they heard. And the whole neighborhood come with them in your office, even if you don't see them. So these patients, they have some belief about flu, how they perceive the flu to be, and how dangerous it is. And it's a very good idea as a physician to listen to these patients and try to understand what exactly they are thinking before you start telling them what to do, and they suddenly don't believe you. You get a glassy eye and they're looking away, and you know you're not going to get much compliance with your very good plan to save them. These are some information we can look at about what the patient really is feeling. What they believe about the flu, they will tell you, oh, it's just a bad cold, or they have a list of all the potential conception, I would say, the patients have. Every physician have heard some of these, and each one of us can come up with our own list. One thing that I saw is that when you go outside in the cold weather, that may give you the flu. Actually, where I grew up in the Caribbean, it's not exactly how it's said. They say if you cool off too fast. It's like if you were riding a bike, you're hot and sweaty, and you go in the shade, take your shirt off. Oh no, you're gonna get sick, because you cool off too fast. The wind, and no, that you can't do that. And I heard the same thing in many other countries in the Caribbean. And they would tell you the stomach flu is another form of the flu. So if I had the stomach flu, I don't need the flu shot. I'm already good. So all these beliefs can kind of hamper the visit. And that's the time you would want, as a physician, to go back and talk to these patients, and better yet, listen to this patient. Because if you're not going to be a good clinician if you cannot listen. And you're not going to listen to any patient if they don't want to talk. They don't want to share their beliefs. Because the last time they tried to talk to another physician, they were dismissed. So what I do in a situation like that, you would see some patient who are reluctant to tell you, did you have your flu shot this year? And the answers are hard to come by. So what I would do in a situation like that, instead of asking the patient to share what they believe, I share with them what I believe. And that's how you open the floodgate. Let me give you an example. A patient I had that didn't really want to tell me anything about the flu because the vaccine, because this patient was clearly against all vaccination. Her kids were not vaccinated, so she had some very strong belief about that. So I told this patient, ma'am, listen, you are here because I have something, I know something that you don't. I have a medical knowledge that you need. You don't have that. But I am taking the time to listen to you, to talk to you, because you have something I don't have. You know something I don't know. You know your family. You know your kids. If your son is 10 years, you have 10 years experience with them. So you know their health so much better than me. My medical knowledge is useless without your help. So once we tell the patient that, they know whatever they tell you will not be dismissed. They know you're willing to listen. And at this point, the floodgates open. That's when they start telling you, oh, this. They will tell you, oh, this is what happened in my neighborhood. This is what study I read, kind of, about vaccine. So you can get the information finally and get the visit back where you need it, where you can have the right information and try to provide the right answers. For lots of patients would come with other alternatives. So you have a chance to tell them about what, as physicians, what we have data and evidence to support the best treatment and the best behavior would be in these situations. Let's talk about one case who is really loaded with these type of things, like a 2-year-old female patient with fever, coughing, headache, and achiness. That's the same thing Dr. Raff was talking about. These symptoms are getting worse over the last 24 hours. The parents live on a farm, and the child is exposed to anything you would normally find on a typical farm. The parents received flu shots 5 years ago, not on a yearly basis, and they got sick and had not been vaccinated since. They got sick from the shot, women. The child has not received flu shot this year, and the mother has been treating this kid with some neighborhood remedies that get from one Amish neighbor. So when somebody come and this is the picture you're dealing with, are you going to tell them, oh, this tonic is really not doing anything? But it saved the neighbor's kid. When you tell them this tonic is not doing anything, you're suddenly in a confrontational situation. And you're pushing against the patient is pushing against you, nobody is listening, and nobody is getting any help. So avoid getting a frustrating day or a frustrating encounter like that. And what's going to help you have a better understanding of the patient's situation is to share with them. Share your own belief. listen to their unbelief, and make sure they understand they will not be dismissed, they will not be looked down upon, and that kind of push the relationship in a positive territory. What we have here is kind of, some physician would use that as a checklist. It's not. And it's not really about the flu. It's about any clinical encounters where you would have a situation with a patient where the situation is not going as fluid as you would want it to go. So you can go back and try to understand the patient's reason to be reticent, the patient's reason to push back against your recommendation or even just against your questions. You should consider these, the patient's age, race, ethnicity, where they are from, their level of education, and by considering that, you have a better way of seeing where the problem is. So you can ask the appropriate question. And by asking the appropriate question, you may end up proposing something the patient can deal with. And it's even better if you can make suggestions instead of giving patients orders. And ask them, how do you feel about trying this or that? We'll give you, in the next slide, a couple of questions that you can ask. Once you identify exactly where your patient is living, where is your patient's mindset, you can ask the right question and get the right answer and have a chance to help this patient. We have these 2 pages printed for you. We can help you get this in your office, because the health belief system is method is how a physician take the time to listen to a patient, to understand their situation, and from there, you're more able to move them where you need them to be. Now, after all of this is done, if your conclusion is that your patient has the flu, then what do we do next? Dr. Awara will tell you about that.
Good morning, everyone, and thank you. I'm an infectious disease physician, but I also do primary care for a portion of my practice in the Baltimore area at Johns Hopkins. And I tell you, Dr. DeMornay, after hearing his talk, you know, you could have been in sales, and I would have bought, you know, swampland from Florida. I mean, I'll do anything you say. Yeah, but I think he makes a very important point that often when we're trying to deal with things so quickly, it's so easy to sort of miss what's really important to the patient to convince them. But turning back more to the science and what Dr. Raff had outlined as well with your experience here, you know, we just celebrated Thanksgiving. And this virus actually takes advantage of our American holiday, because if you look at most years, it spikes right after Thanksgiving. That's when the cases really start in December through January and February are the hot and heavy times. And of course, that's when everyone's getting together and having parties. Influenza is a very smart virus. But let's turn to this current case here that's described just to help frame things. So this is a 32-year-old woman that does present with about 2 days of flu symptoms. And her 3-year-old son, again, that son's in that higher risk group of influenza, had some upper respiratory symptoms. But the patient also had the influenza immunization just a month ago, but she's otherwise healthy and not taking any medications. But, you know, when you're evaluating her, she is febrile, she's tachycardic, she has some increased respiratory rate, and her oxygen saturations are depressed. So this is someone that, you know, sort of falls into clearly having what would be called severe influenza. This is someone that you're going to consider whether you should hospitalize just looking at her vital signs. On exam, she does have some wheezing and abnormalities on the lung exam, and she's a bit sweaty along with tachycardia. And she's influenza A positive, and the chest x-ray does show some patchy diffuse infiltrates suggestive of pneumonia. Now, in this kind of patient, this could be a primary viral pneumonia. It can go this fast and be that severe. But believe it or not, bacterial pneumonia can supervene this fast, especially MRSA pneumonia. More in children at this speed, but even in adults, you know, you can see it at day 2 or 3 with a bacterial pneumonia, but more traditionally around 5 to 7. And as Dr. Raff mentioned, the vaccine efficacy in a given year is variable. It can be as low as 10%, as good as 60%. In the most recent years, the average has been in the 40s. That's for complete prevention. Complete prevention, like you won't get the measles if you had the measles vaccine. Measles vaccine is 98%, 99% effective at completely preventing measles vaccine, generally for lifelong in most cases if they've had the total series and so on. But influenza, it's not that good. But what you may have missed, because it went through fast, is the CDC has done estimates based on pretty carefully done mathematical models. And even 2 years ago, when we had the highest number of flu deaths in the last several decades, over 80,000 flu deaths attributable, the CDC estimated that even when that vaccine didn't work very well, it prevented 7,000 deaths. So what I tell people, even if they're really hesitant, about getting the vaccine, especially if they're in the high-risk group, the vaccine, even if it doesn't fully protect you, it does help prevent serious influenza hospitalizations and death. So it's really to your advantage to try to get it. And last year, as you can see here, there's a little bit of a breakdown with the influenza. And influenza B tends to occur more at the tail end of the symptoms. Now, we're going to talk a little bit of medications. Most of you are familiar with neuraminidase inhibitors. Oseltamivir has been around for a while. It's now generic. This is the one that's primarily used. Now, I think everyone knows this from their basic medical training. Viruses are not alive. They're essentially parasites. They need a host cell to replicate and make new viruses. And with influenza, what happens is the peak viremia, the highest titers, generally are just 24 to 72 hours after symptom onset. That's part of the reason people feel so crummy so fast. And if you think about it, the virus titers, when they're that high, they're going to infect probably all the cells they're going to infect. So if you're giving medications later in the disease course, it's not going to be nearly as effective as starting it very early. And unlike an antibiotic, which kills bacteria, there's no killing here. All the antivirals do is sort of slow down the viral replication. So it's a different method of action, and no matter what drug you give, you have to give it early. I mean, this is true for antibiotics in standard infections, but even especially true for antivirals when you have an acute illness like influenza. And what the neuraminidase inhibitor does, oseltamivir, where does it work in the viral life cycle? So you have an infected cell, it's making new viruses, and it has to actually, new viruses have to leave the infected host cell and bud out. That undocking from the host cell membrane is dependent on neuraminidase to cleave a sialic acid so the new virions can sort of go off and infect another cell. The neuraminidase inhibitors prevent that cleavage so the viruses that have tried to bud and form stay stuck in the host cell. So it really works at the end of the viral life cycle in the cell. And I know I don't want to belabor this too much, but it's important to gauge, because I'm sure most of you are familiar with the 48-hour rule with oseltamivir. So oseltamivir, or Tamiflu, was approved years ago based on a study that looked at uncomplicated influenza in healthy people with less than 48 hours of symptoms. That's how the drug was approved. And what did it do? It reduced influenza by about a day in terms of its symptoms. So, for a healthy person, it's plus minus. Do you want to send them to the drugstore? Have you actually seen them within 48 hours? Most people that are healthy with the flu, they're calling you at day 3 or 4. They want a Z-Pack. Right? They're not even calling you for oseltamivir. So, we don't see a lot of those patients. I won't call them unicorns, but how the drug was approved is really not often how we use it in practice. And I'll tell you a quick story based on some of the data in this table. But what's in the red box is a man by the name of Aoki and colleagues in Manitoba did some studies a few years ago. And it's very interesting. He recruited people in town to try to come in at the first onset of influenza symptoms. between 0 and 6 hours or 6 and 12 hours. Look at the days reduction if they start on the drug really early. So last year, I had influenza. I went to sleep, felt all right going to sleep, and woke up, like Dr. Raff said, felt like I'd been run over by a truck. I had some rigors, I had cough, felt flu-like symptoms and myalgia. I went over to the clinic, I got swabbed, I had influenza A. I picked up an Oseltamivir prescription. I think I started it, I don't know when the symptoms started when I was sleeping, but probably within 8 to 10 hours. And I was really better within about 36 hours after starting the drug, almost 100%. And so I think that correlates with these information, but what it translates to me, I'm a healthcare worker. I didn't want to spread the virus. I wanted to get back to work as soon as possible. But for your high-risk patients, if you can educate them and say, look, if you think you got the flu, even though you got the flu vaccine, let's start on medicine ASAP, and you actually get much more bang for the buck for that. Because again, if you're starting too late, the virus has pretty much done all of its replication and so on. So in terms of antiviral treatment, the complications of flu include, we already talked about a bacterial pneumonia. A lot of times cardiovascular disease is exacerbated, heart failure, COPD, that's a lot of the attributable deaths. And in really severe illness, there can be multi-organ system dysfunction. And what Oseltamivir and other studies have shown is you can reduce illness if you start it early enough. It can also reduce otitis media in kids and other complications. Now, not part of the FDA approval, but how the Centers for Disease Control and the Infectious Disease Society of America and other guidelines have evolved is they've said if you have severe influenza, severe enough to be hospitalized or have any of the major risks for severe influenza that Dr. Raff outlined, you should give Oseltamivir or any antiviral regardless of the duration of symptoms, even if it's beyond 48 hours, because some observational data has suggested it could help reduce complications and illness, even though none of that has been subjected to a rigorous trial. So that's where we sort of stand on this. But last year, actually just exactly a year ago, for the first time in a while, a new drug class has been approved to treat influenza, and that's baloxavir. This is a drug that works differently. It inhibits RNA synthesis of viral-related mRNA by inhibiting the endonuclease, the so-called cap-snatching endonuclease. And this works much earlier in the viral life cycle, just after it uncoats and the virus needs to make its structural and non-structural proteins. It works so, unlike Oseltamivir, which works at the end where the budding occurs. So it actually prevents production of proteins, and it functionally can work sort of faster, is the way I try to think of it. So there are actually 6 treatments FDA approved for influenza, but 2 we haven't used in a decade, and that's amantadine and rimantadine. So most seasonal influenza strains circulating in the last decade have been resistant to that drug class. They're not recommended, and remember, this is only for influenza A, whereas the neuraminidase inhibitors like Oseltamivir, as well as baloxavir, this new drug class, work against both A and B, and to date there has not been abundant resistance with either of those. So in terms of the timing for treatment, we've already talked about the 48-hour rule. So if you're uncomplicated influenza, it's based on your judgment whether you want to go and start the drug or not. Maybe there's other ill people at home. Maybe the patient really wants to sort of have a one-day reduction in illness and so on. So that's a real judgment call whether you go ahead and give the prescription. However, we already talked about on the right-hand side, severe influenza, hospitalized, regardless of the duration of symptoms, it should be started. Although I'll tell you, not a single study, retrospective or observational and so on, has shown any benefit starting after 5 days, because again, probably the virus has done most of its work that it's going to do at that point, and the body's immune response is also complicating the situation. So here's the menu of drugs listed alphabetically. So this new drug, baloxavir, has been approved as a single dose because it has a long half-life of up to 90 hours. And it's weight-based dosing, and it's FDA approved, and I'll go through the data momentarily, ages 12 and older, so adults and so on. Oseltamivir really has been FDA approved for use in anyone 2 weeks of age or older, although is also used in neonates. It is weight-based as well, but you treat for 5 days, twice-a-day dosing. Has anyone here used peramivir at all? So this is an injectable neuraminidase inhibitor, and although approved, just like oseltamivir, for uncomplicated influenza in healthy people, Dr. Raff, you and Dr. Mornay, you don't give injectable drugs in your urgent care, do you? But that's how the drug was approved. But it's used off-label pretty much in the ICU if someone's very ill and can't take oral drugs, or perhaps people with short gut syndrome. And then zanamivir is rarely used anymore. This was approved very early. It's actually the most potent of the neuraminidase inhibitors, but it's an inhaled powder. Can't use it in anyone with asthma, and you already have a respiratory illness. So this really has fallen out of favor, although it remains an option. Now, in terms of safety, let's start with oseltamivir. Generally pretty well tolerated, but remember 10 to 20% of people get nausea and vomiting due to the drug. So especially if you have a healthy person, you may, that's something you may want to sort of think about. Whereas if someone's at high risk, then I don't think that's as much of an issue. The baloxavir trials, interestingly, generally were the same as placebo or numerically better than placebo. So this drug seems to have a very good side effect profile. So let me just go through some of the studies so you can sort of see how this drug was approved and how you might want to think about it within your own clinical practice. This was published last year, Fred Hayden, in the New England Journal, the Capstone 1 trial. This was a trial just like how oseltamivir was approved. The drug was given to healthy people, less than 48 hours, uncomplicated influenza, compared to placebo. And there it reduced duration of illness by about a day. And it was also compared in the oseltamivir arm and worked just about as well. So what you can see here, the main feature, though, that distinguishes it is it shuts down viral shedding faster. And again, because it works earlier in the viral life cycle, you can see placebo, but even compared to oseltamivir, especially in the first few days after administration, it seems to be more effective at reducing viral titer by several logs. Remember, this is a log scale, so it's about 100 times more effective. And then, all these studies have been done to date that we've talked about in healthy people. Actually, just in October, the drug got a new FDA indication. And the FDA indication was for use in exactly the people we want to give it to. That's people who are at high risk for influenza, people with heart failure, asthma, pulmonary hypertension, neurologic disease, etc. So this was a randomized controlled trial. It hasn't yet been published. It's been presented at meetings, but the FDA used this data to give the approval. And you can see here it definitely, compared to placebo, works as well in this population. Interestingly, against influenza B, worked better than oseltamivir for reasons that aren't completely clear. And this study actually had a lot of influenza B for, again, just what was circulating at the time. So the drug does work a little differently. It definitely reduced viral shedding. Oseltamivir was 96 hours till viral shedding stopped versus 48 hours, so about 2 days difference. And there were also fewer antibiotics used in people that got baloxavir. And there were generally fewer influenza-related complications. So as I mentioned, in this trial, it definitely looked like it worked better against influenza B compared to oseltamivir, worked better against viral shedding, and had fairly similar, though, time in terms of alleviating symptoms when you looked at all comers, including influenza A. And was, as I mentioned earlier, at least in this study as well, very well tolerated with a similar incidence in side effects. So this was approved for the treatment of people at high risk for influenza complications in October. So, again, all these indications are for 48 hours or less of symptoms, and I would encourage you and your patients to try to educate to make an early call whether they should be started. Baloxavir has some differences, though, compared to neuraminidase inhibitors. So there are some reduced viral shedding that this drug can achieve, and that might be useful in some settings that you can imagine. The duration of illness, especially, of viral shedding is less. And there were some resistance variants seen. So unlike Oseltamivir, this drug interferes with making proteins and RNA. So there were some mutants seen when virus was shed. We don't know the significance of it, and that's going to be closely monitored during this season. So for neuraminidase inhibitors with complicated illness, there haven't been studies yet to show that the drug is used in that population. We generally have observational data, whereas baloxavir actually has been studied by an RCT that shows that it does work in that patient population, reduced complications, fewer antibiotics, and seem to work better against influenza B compared to Oseltamivir. I'll just close by mentioning a few studies that have not yet been published, but probably will be presented to the FDA soon. The first, I'll go from the bottom. The first is the Blockstone trial. This was a prevention trial, and just like with Oseltamivir. So if you started baloxavir when you came in contact, only about 2% of the time did you develop influenza versus 13%. So again, starting very early upon exposure seemed to work. The Ministone trial, again, was a very traditionally done trial, but in children between 1 and 12 years of age. And remember, children are the ones that actually, they're the vehicles of most transmission. Children are just dangerous. I mean, your grandchildren, so on. You just want to put them in a bubble during the respiratory season because they shed virus at much higher titers. So, the Ministone trial looked like it worked very similar to Oseltamivir, but look at the difference in viral shedding: 24 versus 75 hours. So it definitely shuts down the viral shedding. There was an additional observational study also done in children where it looked like it worked of similar nature. We already talked a little about antiviral resistance. Not a lot of circulating viral resistance for any of the drug classes seen. This continues to be monitored regularly. And so just to close, so for this woman, she probably should be hospitalized. She's hypoxemic and maybe at risk for developing severe disease. Probably she would be started on antibacterials, even though it's a bit early. But she should also be started on antivirals. At the moment, only Oseltamivir is recommended just because there's no data yet for baloxavir in patients who are ill enough to be hospitalized, and of course supportive care. And sometimes patients progress and develop ARDS and so on. So those are the people I consult on in the ICU, and it can be a terrible illness and even strike completely previously healthy people. So just to close, annual influenza immunization is the most effective way to reduce flu. Remember, your recommendation really carries the most weight, but as Dr. DeMornay said, if someone has hesitations, you want to understand them, and that using some of the tools he talked about and understanding can be very helpful. 48 hours are how these drugs have been approved for reduction of symptoms. You can use them after that for severely ill patients, but again, you're going to get much more out of these drugs the earlier you give them. And remember to consider the antivirals, even if patients are beyond the 48 hours, if they're presenting to your urgent care clinic, your office, if they're at high risk, because that's currently what the guidelines recommend, although the data is not of the highest quality. That is the current recommendations, mainly because the drugs don't have a lot of side effects. So I think we're at the question and answer. Is that right at this point, Dr. Ray? Okay. There are two vaccines approved at the moment by the FDA for seniors over 65. The high-dose flu vaccine that has a higher amount of antigen in it. But there's also another one that has an adjuvant, MF59, that is a squalene-based emulsion that also generates higher titers. The high-dose flu vaccine has been shown in a 2014 New England Journal to actually help decrease by about 24% compared to standard vaccine influenza illness. So it does seem to be more effective. You know, seniors probably don't have as much of a robust immune response. So, and the adjuvant one is going to be compared head-to-head this season with that. So they're available. You know, they're not in as much supply, so a lot of seniors this year have had trouble finding the high-dose vaccine except at the drugstores, because we never got our delivery, for example, because Walgreens and CVS sopped them all up, you know, so they have much more purchasing power. So those approaches are being looked at. The second question was telemedicine and e-visits. My feeling is if you have someone that's at low risk for complications, e-visits are ideal. Why bring them in the office? I don't want to get infected. I don't want to see them. But if someone is at high risk, you may want to bring them in because you need to get vital signs. You know, are they at high risk for complications? Do you want to start, do they have influenza? You may want to do molecular testing or not. So there are those decisions, and I would say anyone at high risk, you'd probably want to bring in the office and physically do an exam and listen to their lungs. But, you know, that's a judgment call, you know, based on how they look, you know, if they, you know. So telemedicine may still have a triage role, but if you're thinking about influenza, I'd be a little more concerned.
Hello. Is there any value in having the antivirals at home prior? Like if you're saying 0 to 12 hours or 0 to 6 hours, instead of
so the question was standby therapy. What about having the drug on home for the high-risk patient? You know, that's an interesting approach. I mean, it's been used in malaria and studied. I have not seen it in influenza, but it makes some sense for the very high-risk patients because if you think about it, by the time you either see them or have them diagnosed and they have to go to the drugstore, if you're in the middle of seasonal influenza season, high-risk patient, you could argue that. Now, on the other hand, do we want as much drug circulating around being taken inappropriately that might lead to emergence of some resistance? I think that's one of the reasons why healthy people with influenza, there's always been the tendency, honestly, not to give any kind of antivirals there because you don't have as much benefit and, you know, and by the time people get the drug, unlike in research studies, they're usually beyond 48 hours by the time they get to the first dose, and you're already losing hours at that time. So I think that's an excellent question and one that probably is worthy of study.
I wanted to go back on this e-visit for the flu. What I think would be the best indication for an e-visit would be if you have a healthy patient who is not a high risk for complication, and you are in the middle of the season, so you know exactly what's going on in the community. These patients are less likely to be tested, even if they come in the office. So even if you cannot test them, that's okay, because most of these patients are going to be treated on your clinical evaluation. So these patients would be ideal to keep them at home, do an e-visit, and just send the prescription. But if you're thinking of extremes, older patients, younger patients, or high risk for complications, you want to actually see these patients.
So the question is, any problems with availability of Tamiflu? I've only been in this area practicing for a couple years. I've not seen that to be an issue, but Dave, you've been here a lot longer than I have.
At some point it has been. I think in the maybe last 2 or 3 years, I heard that, maybe 5 years even, I heard that we run out of Tamiflu. So now we're kind of saving it. Even if a patient does have the flu, we would treat, and we don't have medication, we save for sicker patients.
The major time was during the pandemic 10 years ago, and you know, everybody wanted to stock it on hand. Or there was a time when bird flu was, you know, sort of popularized in the lay press, and so people were stockpiling it. And so I think I would just hear from the public health authorities because they'll alert you if there are shortages. In the last years, it's only been occasional ones, generally when there's only one manufacturer of the suspension, for example. But that's always a concern, and I think that's why if there's a concern for shortages, then you tilt to high-risk patients, hospitalized patients only.
Well, if there's no other questions, thank you very much for joining us here today, and have a great day.